So this second half of the morning session is devoted to myeloproliferative neoplasms, which make a nice contrast, and actually there's a lot of similarities with MDS, being that we're talking about clonal stem cell disorders. And I'm going to be talking about cytokine cells and inflammation in the myeloproliferative neoplasms. And I want to just start with a little segue here. You all know what these diseases are. And you know they're clonal stem cell diseases like the myelodysplasia, and that they can there's overproduction in these diseases of one or more of the formed elements of the blood, unlike myelodysplasia, except perhaps 5q- syndrome, and sideroblastic anemia, which is partly an MPN type disease. And they progressed in some cases to extramedullary hematopoiesis, myelofibrosis, bone marrow failure, and acute leukemia. So they all three have similar characteristics at different rates. And the diseases are that way because they share in a variety of mutations, the most common of which is the JAK2 V617F mutation. And polycythemia vera is obviously the commonest of these disorders, and the first one we should always think about. And one of the things these disorders do is they engage in phenotypic mimicry, which is a little different from genotypic abnormalities. And so what looks like essential thrombocytosis, if you're a man, may end up as primary myelofibrosis, or if you're a woman, as polycythemia vera. And if you have myelofibrosis, you can go to polycythemia vera and vice versa. But all pathways lead in that direction. And there's a reason for that. As you can see on the slide, the pluripotent stem cells here, lymphocytes here, and then the common pathway. And each of these progenitor cells requires JAK2. It's obligatory. And so this is sort of like an onco-addiction. So polycythemia vera is the ultimate expression of the JAK2 V617F mutation in a phenotypic manner. Now, it so happens that people have looked at these diseases, they get the same mutation, and if you look at ET and you look at PV, and you see this continuum, they seem to overlap. And if you look at the hematocrit values, they seem to overlap. Not true, because hematocrit doesn't tell you what the red cell mass is. But up has come this conclusion that ET and PV appear to be a continuum. And so now we come back to and so are these three disorders different disorders? Or are they different manifestations of the same disorder? And I will tell you that they are three different disorders. So very briefly, if you look at this slide, you have disease duration on this axis. You have the JAK2 V617 allele burden, because we have the most information on these axes. And this is ET, PV, and PMF. And do you see anything that makes these look the same? ET rarely ever gets above 50% allele burden. Okay, PV starts out that way, but it goes in this direction. And PMF is usually always totally clonally dominant. And if you'll see here, the males have a higher allele burden than females, and there are more males, or this is probably equal here. There's more females here. These are close to equal, but maybe more females. But here, there are more males, but the allele burden in females is higher. So really, it's hard to make them the same disease. And if you do gene expression profiling, which was talked about earlier today, you find out two things. I found out this was a nifty way to tell men from women. And you think I jest. Women with PV dysregulate half the number of genes that men do. And in ET, it goes the other way around. But the men and women each dysregulate a core. Here, 102 genes, here 17 genes. So there's 6 times more genes deregulated in PV in the core pathway than in ET. They can't be the same disease. And then here, if you look at survival, what you find out is here's the survival of ET, it's almost normal. Here is PV, here's PMF. So why do I tell you that? Well, I hope you can see this. This is 2 articles from a leading journal in hematology, Blood, where PV and ET are conflated. And if you just look at the hemoglobin values in each, okay? And there's this overlap. Now, if you believe in the World Health Organization diagnostic criteria, which I do not, then you'd have to say that some of the ET patients must have PV. So, now, why do these diseases look like they overlap? And let's come back to the stem cell again. And this is the latest reiteration of the dogma of hematology. Instead of the pluripotent stem cell going here and going here, lymphoid and myeloid, there is side pathways. You can, this so-called myeloid repopulating cell, it's a long-term repopulating cell, and it can be either megakaryocytic erythroid, or erythroid, myeloid, and megakaryocytic. So if things happen down here, you can get ET, you can get PV in several varieties, and you can switch back and forth. Or you can go all the way down here. Now look up here. We have all these growth factors that are operative down at this level, but we only have the thrombopoietin receptor operative in the hematopoietic stem cell. And that's sort of the key to everything. So it turns out now, and this is from a mouse model, here we have the pluripotent stem cell. In inflammation, the megakaryocytic stem cell is preferentially activated and then goes down in this direction. So you do get an increase in, if you look at causes of thrombocytosis, many of these are due to inflammation. So that's activation of that stem cell. And if you look at causes of myelofibrosis, many of them are associated with a high platelet count, and in some cases, an activation of that megakaryocytic stem cell. Now, what else do we know about the MPN? We know that in each NPN, and we don't have time to go into this today, plasma thrombopoietin levels are elevated. So what does thrombopoietin do? Well, thrombopoietin increases TGF-beta. And what does TGF-beta do? TGF-beta causes marrow fibrosis. So this is a model of a mouse with overproduction of thrombopoietin, and here's the normal mouse histology. And here, there's hyperplasia in the marrow and increased megakaryocytes. There's increased fibrosis, and there is increased reticulum. If you transplant the mouse, everything goes away. Now, I want to show you an unpublished model from our lab of a mouse with polycythemia vera, JAK2 V617F positive mouse, and here's the bone marrow with a carpet of megakaryocytes, hypercellular, and here's the bone marrow again, same mouse, osteomyelofibrosis. If we knock out the thrombopoietin receptor, the mouse returns to normal, but that's a dog and pony trick. What if you just knock out thrombopoietin? The mouse returns to close to normal, and the spleen shrinks down in size. So if you wanted to attack a disease, thrombopoietin is the cytokine that you would attack. But let's go back to our friend JAK2, and these are all the different cytokine receptors. And what you see here, this is the only cytokine receptors that do not require JAK2. What the rest of these all have in common is they don't have an intrinsic kinase domain, such as you would see in the PDGF receptor, the c-KIT receptor, the fibroblast growth factor receptor. They require a tyrosine kinase, and JAK2 is the cognate tyrosine kinase for the growth factor receptors, and then for receptors that are involved in the immune system. Now, why is that important? I know this slide is hard to see, but it's a fact of life. This is a list of all the circulating cytokines that are elevated in patients with primary myelofibrosis. And it's quite a list. I mean, it's just, it's amazing. And I only want to talk about one at the moment from there, and that's TNF. Now, this is a nice study in blood looking at TNF levels in patients with myeloproliferative disorders. And what you will see here, this is ET, PV, and PMF, and you will see that the cytokines, the TNF is elevated in all, but it's most elevated compared to control patients in primary myelofibrosis patients and secondary myelofibrosis patients. And here's the JAK2 allele burden, and here's the TNF levels. You can see it's a really nice correlation. The higher the JAK2 allele burden, the more TNF. And so how does that happen? Well, for a couple of reasons. One, you're going to have more cells that have the mutation, and they will be making TNF. So that's the main reason. And they'll be telling other cells to do this too. And this brings me back to a favorite topic of mine, erythropoiesis. And in erythropoiesis, you have the BFUE, the earliest recognizable form, then the CFUE. And you go down the pathway here to the early proerythroblasts, the basophilic proerythroblasts. And then you get down here to the more committed, totally committed cells. And erythropoietin is required up here. It's not required for differentiation. But some interesting things are FAS and TRAIL and TNF receptor and interferon gamma and caspase 3, which is a death enzyme. And what are these things doing? Well, if you don't have these products, gene products, you can't mature a red cell. If you have these products and you don't have erythropoietin, the red cells die. Caspase 3 is to lyse the nucleus, but if you don't have erythropoietin around, caspase 3 is going to kill the cell. So the red cell's walking on a very narrow pathway, and of course, if you have increased TNF and decreased erythropoietin, as I'll show you in these diseases, you're going to kill your red cells. Now, I want to show you that slide with this slide. So this is a very nice study from Italy. There are 687 patients with polycythemia vera, of which only 66, 11%, had the so-called post-polycythemia vera myelofibrosis bone marrow failure syndrome. So it's not happening in everybody. And notice they all have myelofibrosis, but here are the patients with myelofibrosis who have no cytopenias. And the reason I show you this is to make the point that myelofibrosis is a reactive, reversible condition in the bone marrow. Not true in the lung or in the kidney or in the liver, but in the bone marrow, it's reversible. It does not cause bone marrow failure. It is a bad stem cell that's causing the bone marrow failure. So you can have the myelofibrosis, but if you have a bad stem cell, then you start to shorten your lifespan. Okay. Now, let's go back to the polycythemia vera patients with 102 the core genes. And I didn't know what the speakers were going to say before today, but you know, you heard about toll-like receptors. Well, S100A9 is one of the genes that's upregulated in polycythemia vera, so it probably contributes to the inflammation. No one's talked about it. We've published this, but we didn't get into that aspect. But one of the things that happens in polycythemia vera is this. The CD34 positive cells have a stromal gene list that's upregulated. So these cells are telling the rest of the bone marrow, we're going to make collagen. Spark is one of the key elements for bone marrow fibrosis and all the collagen elements. So this is the stromal cells, the CD34 positive cells dictating to the marrow you're going to make fibrosis. And there's some other things I don't have time to go into today. For instance, people are always looking for something other than hyperviscosity causing clotting in polycythemia vera. Well, if you want to look, here they are. But I want to look over here. So these cells are secreting things like complement factor D, long pentraxin 3, and so there's a whole list of things, MIP1 alpha, CCL5, but I want to concentrate on one. So you get complement activation in these diseases, and you get these adipokines. Adipokines are inflammatory. And I want to talk about one, which is LCN2, or lipocalin. This is a study published by Ron Hoffman on potential effects of lipocalin, LCN2, in the MPN. This came up in our gene expression profiling, so he took that data and went ahead and studied this. It's published in Blood. And what you have lipocalin doing, being secreted by the malignant stem cell, is it's killing off the normal stem cell population, increasing reactive oxygen species, causing double-stranded DNA breaks, killing these cells, but not touching the malignant cell population. It's sort of like a fungus killing off bacteria by making an antibiotic. And then you have the same cells, the LCN2 from the CD34 positive cells, telling the stroma, go do the following things. So you have a terribly reactive cycle going on in the bone marrow, sort of a vicious cycle. And so what you end up with in the advanced stages of an MPN is a patient whose spleen has gone from here, gone to here, gone to here, and you can see the liver, this is associated, the spleen is an energy sump. You end up with a cachexia occurring. Now, these are two heat maps in patients with myelofibrosis, primary or secondary, in the untreated stage. And the red here, it's a nice color because it's used to say what inflammatory cytokines are increased. And if you look here, you can see this whole list. So these people are on fire. And what are they not making? They're not making erythropoietin. When these patients are treated with ruxolitinib, what happens? All of a sudden, you're not making these cytokines, but you are making erythropoietin. You've just turned a switch here. Now, what happens if you actually look at inflammatory cytokine production, this is from one of Serge's nice studies, clinical studies, that you actually decrease to a greater or lesser extent in most patients. These are the ones that happen to be measured. Notice TNF-alpha, the various cytokines are reduced in production because you've inhibited JAK2 V617F, which is in cells responsible for making immune cytokines. And then, of course, what happens is that patients feel better. Their itching goes away, their bone pain goes away, their weight goes up in proportion to how much they weighed before. The thinner they were, the more weight they gained back. I don't have time to show you in this presentation that the change in weight is proportional to the change in spleen size, so that the patients with the largest spleen size, the largest amount of shrinkage, you get the weight go up. If you don't have, your spleen's not that big, you're not going to have lost that much weight. Now, this is hard to see, but this is a slide showing, again, people taking ruxolitinib. Duration in time is here in the x-axis, and you can see in the controls, no weight goes up, but in the patients who are on ruxolitinib, body weight goes up, cholesterol goes up, the albumin level goes up. I can tell you a half-funny anecdote. I had an extremely bright patient, and since we're down in Washington, Donald Trump thought he was the best entrepreneur he ever knew, and in this case, Donald Trump was actually right. And this gentleman had actually an MDS with a huge spleen, CMMOL, and he liked to read a lot. And cholesterol is important, and his cholesterol was low. And he decided that was a bad thing. And he asked me, well, why is my cholesterol low? I said, because your spleen is so big. But he said, I'm going to get my cholesterol up. He didn't tell me. And he started eating a lot of eggs. And he happened to have, at the time, a splenic infarct. He came into the hospital, and he had a little fever. So we did a blood culture, and of course, you eat enough eggs, you're going to get salmonella. And so he had a salmonella sepsis in addition to everything else going on. So now, so if you have increased inflammatory cytokines, what happens to the patient? Well, this slide from the Mayo Clinic, looking at just two cytokines, IL-8 and IL-2R. And this is time and this is survival. And if you look here, you'll see that this is survival of people who don't have these two cytokine levels elevated, and here are patients who do. So not only do people feel better and their cytokine levels are lowered, but if they're not lowered, their mortality goes up. And this, my final slide, is from one of Serge's studies, overall survival with ruxolitinib in an intention to treat population. And what you can see is that ruxolitinib in this study improve survival over placebo. And I think that's now even more solidified, so that we actually, by reducing inflammatory cytokine production, patients live longer. And I think it's not only the cachexia, but you don't shrink spleens by just stopping inflammatory cytokines. When you inhibit these inflammatory cytokines, what you're doing is then breaking up the vicious cycle where cells inhibit normal cells and also help produce more of their own kind. So let me stop here and make the points that the three myeloproliferative disorders may look phenotypically alike, but you have to look beyond phenotype and look at genotype. They are different disorders. They have different complication rates, and so when you read about all the thromboses in patients with ET, remember that if you try and diagnose ET on the basis of hematocrit, you'll be wrong 64% of the time, and probably at a minimum. So the other thing that happens in these disorders, and I didn't get time to get into it, they have a decreased surface receptors. MPL goes down, thrombopoietin goes up, right? And thrombopoietin, as you know, causes myelofibrosis and will increase the production of myeloproliferative stem cells. And if you inhibit JAK2 V617F, you will reduce the production of inflammatory cytokines and improve survival. And if you inhibit thrombopoietin, which you've only done experimentally, I suspect you will also inhibit the disease as well. And I'll stop right there.